second it is in technology, this one.
Take this there.
Yeah.
Take your pen back.
If you want to cancel here, I can have another pen.
No, don't worry. Got it.
Yeah.
We're good. So where is our session?
Here.
What is it? Oh, best practices. Should we start?
It starts at
1:15.
15. Yeah. Like that.
So I'll introduce myself and you will introduce yourself. Good afternoon, everyone. Hello, everyone. Thanks for joining us this afternoon and during lunch break. My name is Nadine Cronfley. I'm an infectious disease specialist and clinician scientist at McGill University. And co-chairing with me is Joaquin Cabezas.
As Nadine said, my name is Joaquin Cabezas. I'm a hepatologist in the north of Spain, in Santander. I'm also focused in prison setting, but I work as an hepatologist.
So INHSU Prisons has put this lunchtime event together, and we focused on regional spotlights, primarily the UK, the European Union, and Asia on harm. Actually, we don't have an Asia. Oh, yes, we do. I lie. Iran will be with us. So we'll be focusing on harm reduction and hepatitis C in correctional settings, and I must say we're very privileged to have some phenomenal speakers with us this afternoon. So we'll start off by presenting Svetlana Doltu, who's an international expert on the right to health in prisons, especially in the field of tuberculosis, HIV, drug addiction, and harm reduction services. Before becoming the NGO Act for Involvement Director, Dr. Doltu was the head of the medical department in the penitentiary system of the Republic of Moldova. So welcome, Dr. Doltu.
Hello, dear colleagues. I am very happy to be here because this was a very long way from the first line doctor in prisons through this position. And I think this is a dream for all our doctors working in prison through the mirror of discrimination to this type of professional that work with these vulnerable groups. But I think Moldova is also a very small country. If you see, it's a small country between Ukraine, about war you know currently, and between Romania. We are a very small country, and this context, I think, is a privilege, because we are only 4 million people in all our country. We have 17 prisons, but the incarceration rate is very high if you compare with European media. But occupancy rate is about 90%. Really, in prison system, we have about 7,000 people, and is annually average about 10,000 people. Regarding the health profile of not prisoners, but people living in prisons, maybe will be more polite. The first problem is HIV prevention, HIV prevalence. If you see, about 7% of prisoners have these diseases. The second is different type of dependency. We discussed not only about drug dependency, but also about alcohol dependency, because Moldova is famous with its very good wine, but this is a problem of public health. TB prevalence, it's only 1% among prisoners, but our country is one of the 8 countries of the old level with high burden of MDR tuberculosis. And this 1% can be a very big challenge when we have patients with 3 diseases. Not only one type of treatment, but it's very difficult to manage side effects for each of these maybe 10 MDR drugs, also methadone or buprenorphine, also HIV medication, and there are a lot of difficulties because general health status of our prisoners also it's not so good. HIV prevalence is also about 3%. This situation, and due to a very small country, we have also a second very big problem: resources, lack of resources. And we discuss not only about money, but also about human resources. Because Romania, nearest our country, we have the similar language. In Moldova, language is also Romania, and a lot of our doctors come out to work in Romania, that is in one UE country, and is better paid. And this lack of human resources and doctors, it's very a big challenge for prison systems. Because as a situation at the finished of last year, from 17 prisons, in 10 there are no medical doctors. Only nurses that they need to implement of our current daily activities for medical staff and to ensure access of prisoners for services. But if you discuss about standard and recommended WHO, UNODC, UNAIDS comprehensive package of services, Moldovan prison system management always promote the implementation of new services and ensured equivalence of care between community and prison system. We have also a second good point. We have a lot of years sponsored and financial support of Global Fund, and this promote and ensure a very easy implementation of services in community and prisons also. This is a way that are ensuring and ensured the access of prisoners for all necessary services. If you discuss about these 15 interventions, currently Moldova implement fully 13 of them. There are no implemented the prevention of sexual violence. We have only a small intervention among MSM because the specific group in line with HIV prevention measure. And also we have no prevention of transmission through tattooing and piercing. This, if you see, it's more security, maybe public health program than medical problem, but that needs to have a very good advocacy from prison medical staff in discussion with decision maker, not only in community, but especially from ranged bosses. How we achieve that? There are more than 20 years from beginning the implementation of harm reduction intervention in prison system. The first interventions was in 1999, and we started with NSP program and condom provision in prison system. But I think the best way what we followed was starting the implementation through NGO in community in prison also, and after we have a graduate transferring of the responsibility for the prison authorities. And this was our experience, but through this different intervention and different stage of implementation for each of one, we always have a very good communication and open gates for former prisoners, for the community representative, key affected population to provide the services in prisons. And this is a good point to have a similar approach and to promote our services that are similar as in community also. 2 years ago, the comprehensive package of services changed the aspect. Now we have 8 activities in prevention on HIV and hepatitis. And if you discuss about Moldova, I put first it's information and education, because this is entry gates for all next interventions. It's very important to reduce rigidity and negativism among non-medical staff, because usually for doctors it's very clear, prevention measure, it's less work after to treat the patients. But to convince the prison authorities is very important, and this it's clear only with linkage with health situation of staff, because the risk to work in prison increase if you don't have this prevention measure for all of people who are in prisons. We discussed about staff and also about prisoners. Second measure that also maybe it's a challenge for all our former Soviet Union space, it's opioid-assisted therapy. As you see, this therapy was implemented in Moldova in 2005 in the simultaneous times like in community, and this is our best practice maybe, because all the activities of medical treatments available in the country are done by prison medical staff only according with the national guidelines. And for us, for prison system, we have the same diagnostic approach, the same harm reduction approach. Maybe only for the specific implementation in prison, we have some specific procedure that delimited the medical activities and the activities of security staff. But usually, we try to follow all the national and international standards for the community. Hepatitis B vaccination. Usually in Moldova, it's only one national program, and it's using when are baby, the people, this vaccination. But our last implemented interventions is this year. We started the vaccination on hepatitis B for prison staff and for prisoners. This is in with purpose to follow the international recommendation to do this. Post-exposure prophylaxis are available starting with HIV treatment in prisons, the same 2005 years. But we have no PrEP in prison. This also is a challenge because currently there are no very clear aspects, instruction how to do this in prison settings, but it's our next challenge, and we hope to solve this problem. And how I mentioned before, we have no transmission through tattooing, piercing, and other form of skin penetration, but it's a very strange changing of priorities maybe, because our prisoners usually when they need to provide a tattoo, they use the same need-searing exchange program. And this activity is safety, in my opinion, but there are no agreement how to do this. A lot of people maybe have a tattoo in the community, but criminal subculture in prisons, especially in our former Soviet Union country, decrease this idea and this fashion to do tattoo. This is one side of needle exchange program. Our needle exchange program is conducted and continue to be conducted only peer-to-peer. We have special trained volunteers among prisoners. Also, this service is available through medical units, but usually prisoners like to use anonymous peer-to-peer changing. This is a very old images. Now situation is better, but it's very important to understand when we started this needle exchange program, this is a accommodation for prisoners. This was the situation. The biggest challenge, like we need a better condition to start to do something, it's incorrect for our countries. The same is methadone assisted treatment, always implemented through medical staff. We had about 15 years only methadone. From 2 years, we have also buprenorphine in prison system on the same protocol like community. Treatment is also clear. We have the same protocol. Treatment is ensured, especially for 3 same very important diseases. But the biggest challenge was to exclude mandatory testing for prisoners in 2007, and currently this testing is available through medical staff, NGO, peer-to-peer, and also we have now self-testing system for prisoners also. Gender-responsive services. Also, we have a small number of women in prisons. It's about 5% of them, but the same services are available in prisons for men and for women. And additionally, we have some trainings and tools to promote gender-responsive activities. We have a lot of additional measures, but this is like a general accommodation for prisoners. But we have hygienic kits for women if it's necessary, and maybe some additional food for babies if it's available, and contraceptive also. Safety and health for prison staff. It's the main important point when we need to change situation in prisons, and each year all prison staff at central level, at prison level, have a lot of trainings regarding different health topics, not about TB, not about HIV or hepatitis, but always its linkage with their currently activities, and motivate them to ensure access of detainees to health care, and especially when we discuss about methadone or needle exchange program. Last year, we are part of a very good regional initiative, COVID-19 vaccination in prisons, and we are happy to be part of this 6 country who tried to promote the vaccination services for detainees. That is not part of comprehensive package of services, but is very important when we discuss about human rights. Moldova have a very good access for voluntary vaccination. This is very clear. There are no involuntary vaccination, and people living in prisons have now a higher percent of vaccinations than general population in Moldova. If you discuss about women in prisons, the vaccination rate is about 19%, because it depends on the motivation of people. Research is in prisons, a very interesting topic. It's very difficult to explain one hand for prison authorities what is important to have this intervention and what is human rights. Usually in prison system we use IBBS, the same methodology as in community, and we collect the data regarding the impact of our intervention. And if you saw, you have a very good result regarding using of sterile equipment. We have a very good integrated knowledge regarding tuberculosis, that is also a problem. Average age increased. It's also very interesting. Maybe we have a same slot of different people who live in prisons with drug dependency. We have a lot of estimating exercises regarding how much people who inject drug we have in prisons. It's not too much. We have about 1,000 people annually. From these 10,000 people who went through prison system each year. HIV, hepatitis B, C prevalence decrease, and this is a good point that harm reduction program works, and this is a good for public health and for the health of non-medical and medical staff in prisons. Sure, you have lessons learned, and for us this is 20 years of experience. Usually the biggest challenge that comprehensive package can't be implemented in prisons. It's not correct. It's true, but it's need to identify very specific national context to include or to promote one of services, yes. Better is to implement in all country all services without discrimination of status of prisoners. Information and education of prison staff and prisoners also is very important, because when we have a service and it is accessible, we have a challenge that service can be unacceptable for the prison staff. This is more in line with discrimination and stigma of different type of prisoners, because they also, in our country, there are a lot of criminal subculture aspects and group castes, and it's important to manage this situation also. Equivalence of care in prison and community is a right to health, not only HIV prevention, and help us regularly CPT visits in Moldova that they mention as a good practice, our harm reduction services, and this is a challenge to maintain these activities when the management of prison system change. But it's important to have all approaches, not medical, but human rights approach also. Integrated people-centered care is the best model because we have one people but a lot of different diseases. Researches and studies. We have not only IBSS studies but also good collaboration with Yale University to collect and to promote our good practices in the world model. NGO and donor support also is important. Thank you very much and sorry for the delay.
Thank you
Thank
so
you.
much, Svetlana. How can we cut someone off who's come all the way from Moldova to speak here? So we're going to leave the questions until the end of the session.
Yes. Thank you.
So now it's time for Ian Brew, who is a GP and a Deputy Medical Director with England's largest provider in prison healthcare. He's involved in treating hepatitis C since 1993, focused on its elimination. And his talk is about enhancing hepatitis C testing and treatment in correctional setting in the UK, advances and remaining challenges. The floor is yours, Ian. Thank you.
Thank you very much indeed. I can probably trim us down a couple of minutes, so
Thank you.
I think it was fascinating to hear from Svetlana, so thanks for that. One of the things that I've heard a lot about over the last few days at a couple of different conferences, actually, is the need for collaboration. And the project that we've been doing in Practice Plus Group, who provide healthcare to 50 of England's prisons, would not have been possible without the collaboration of the Hepatitis C Trust, who've been doing the peer advocacy and peer support, and they've been intimately involved in all of the work that we've done. And supported by Gilead as well, who've been working with NHS England around case finding, so finding people infected, getting them treated and getting them cured. So that's an outline of where we deliver services around the country. It's just England, so I'm not going to try and cover the whole UK. But our model is one of opt-out testing in prisoner reception as people come through the gate. That's supposed to have been opt-out since 2014, but as you'll see in one of the next slides, in 2018 we were really rubbish, and I think that's one of the reasons that NHS England and Gilead sought us out. An early change that we made is to move away from dry blood spot testing. So that's 5 dots of blood on a card that gets sent to a lab. The blood is eluted into a test tube, which is then tested, and you might get a result back 2 weeks later, by which time the patient has gone. So we changed to a point-of-care antibody test for all 3 BBVs. So that gives us antibody positivity within 15 minutes, and then we're able to link people to care much more easily. We were aiming for 95% of our population coming in tested, and 90% of those who are RNA positive then linked to care. And I've always referred to this as a ring fence. So we want to put a tight ring fence around our prisons. So the padlock is a bit unfortunate, isn't it, when we're talking about prisons? But it's meant to be a secure ring. Right. So what have we done? Hopefully that's a dot. That's brilliant. So here's where we started. We were not doing very well. We were offering tests to 92% 2% of people, and of those, we were testing 40%. So that's pretty poor, and that's in May 2019, as you can see. Something global happened here. We were doing really, really well, and then something, I can't remember what it was, but anyway. So we had a dip there, as you will see in just a second. But then we were able to pick up quite rapidly, and you can see that over the last year or so, we've managed to maintain a pretty good ring fence. So I'm really pleased with that. If that would like to move on, that would be good. There we go. Yeah, so those are the COVID lockdowns in the UK. And you can see the first one affected us very badly. The second, actually hardly at all, because this was embedded as practice. So that's great. You've got your ring fence in place, but once you've done that, there are a lot of people who've been in jail for a long time. So you have to wipe the jail clear of Hep C. And we've been doing that by doing HITS, high intensity test and treat programs. And when you do one of those and you clear the prison of RNA positivity, that's how we're looking to achieve elimination. As I say, absolutely none of this could have been done without the tight collaboration between NHS England, the Hep C Trust, Gilead, and my organisation, Practice Plus Group. But let's not forget that you can't do this without the cooperation of the prison as well. So HMPPS on board, really important. And I'd just like to echo Svetlana's point that actually you make your prison staff, your non-medical and medical staff, safer by eliminating bloodborne viruses, because violence does happen in prisons, unfortunately, and that can be pretty unpredictable. So let's have a look at what we've managed to achieve, bearing in mind that at the start of this programme, we were only testing 29% of the people who came through the door. We churn about 53,000 patients a year through our 50 prisons. So if you're testing a quarter of those, my maths is terrible. We weren't doing very well. But what have we done since 2019? Well, in reception, we've done 93,000 tests, and in HITS, around several of our prisons, we've done 45,000 point-of-care tests. So that's nearly 140,000 people tested, bearing in mind that our population's 53,000 at any point. So we've tested everyone 3 times, you could say. So up to Q2 23, this is about linkage to care. We tested just shy of 80,000 people in reception over that 3-year period. Of those antibody positives, 5.4%, and that's really crucial information, because I can remember advising on the early days of the Hep C in the UK report, when we were doing targeted testing for Hep C positivity, we were finding about 20%. So when we went looking for people with known risk factors and tested them, of course the prevalence was much higher. And those data informed some of the estimates that were made by the epidemiologists. And we never had reliable antibody data on huge numbers of prisoners. So we've got that now. So we know it's 5.4%. I can tell you that in some of the female sites, that's as high as 29%. So women with the associated trauma, much more likely to be Hep C positive. And I was astonished by that. I mean, that's nearly 6 times the average prevalence, which goes to show quite a few things. Of those, we found 2,267 new RNA positive patients. And we used to be quite good at finding people, but we were rubbish at linking them to care. So I'm really pleased to say that 92.5% of those people have been linked to care and had the opportunity of cure. I'm not quite sure what our data looks like in terms of SVR and being lost to follow-up. Our population does have a tendency of getting lost to follow-up sometimes. I'm delighted, by the way, to hear that we're across a number of organisations, we're no longer talking about people who are hard to reach. We're talking about our services being hard to access. And health literacy, I think, is something that we really need to think about going forward. So, 2,100 people have had their treatment initiation. So, what does that actually mean? Well, here is our antibody positivity rate, just under 6% there. But look at the RNA positivity. Look what's happened to that. That's nearly halved from 5% to just over 2%. Now, I'm not a statistician, but that tells me that we've treated about half of the Hep C positive patients available to us. And I think I've noticed this quite long tail. Unfortunately, not all prisons are able to replicate the successes that we've had. And that means that without getting that linkage and that consistency across the board, I think we're going to have quite a long, you might call it a tail of people to treat. But the good thing is that that'll keep me busy for the rest of my career, and probably a couple of the younger hepatologists that I've been talking to as well. So I think that those are quite pleasing data. They show that things are moving on. Further advances, well, we want to get even quicker at getting people into treatment. When I first started as a GP in prison, and then working at Leeds prison, big remand prison in 2006, it took 3 visits to healthcare, 3 lots of blood tests before you even got referred for an ultrasound test with a view to hepatology referral. Well, we changed all that to a one-stop shop with blood tests. And we were getting people referred within 4 to 6 weeks, and we thought that was brilliant. Well, the gene expert has changed things again, and we've now got in several of our sites a gene expert which will give us an RNA result within an hour. So we can do a point-of-care antibody test. That's positive. Move on to a CEFID test. 1 hour, we have an RNA result and make the referral to hepatology essentially the same day. And we've seen some treatment starts within 48, 72 hours, which is just astonishing compared to where we were. At HMP Hewell, they got their CEFID machine in April this year. Since then, they've had just under 1,900 receptions. They found 53 positive RNA cases, which is just under 3% of the population there, and 50 treatment starts. So of that 53, 50 have got straight into treatment, which is amazing. Just to reflect on a couple of challenges that we've got now, there's a migrant population. My organisation is now looking after 2 detention centres to try our best to provide good healthcare to migrants who are in difficulty with the border force. We're now testing those people as they come in, and NHS England have agreed to fund full treatment for anyone who's RNA positive. But they're often very short stay. They're often in and out within 3 days, which makes it really challenging. And, of course, these are people who may well mistrust authority figures. Other short stay settings, so police custody. It would be lovely to do this work in police custody, but it's such short periods of time. And I think the number of plates everyone has spinning, it's really important to recognise that it's difficult to prioritise BBV and Hep C elimination amongst everything else that people are trying to deliver. And finally, our patients who just don't know they're at risk. They may have indulged in some behaviour 30 years ago, all forgotten. They don't know they're at risk. They're going to be really, really hard to find. And very small numbers of patients who actually don't want treatment. So I said ask me 2 questions, but I think we're probably going to do that in the Q&A session. Thank you very much.
Thanks, Ian. Thanks very much, Ian. We'll move on to our final talk by Dr. Miriam Alavi, who is here actually with us virtually. She is from the Viral Hepatitis Clinical Research Program at the Kirby Institute at the University of New South Wales from Australia. And she'll be here or virtually presenting to us on hepatitis C and harm reduction in custodial settings in Iran. Welcome, Miriam, and thanks for joining us.
Hello, we'll be talking a little bit about hepatitis C and harm reduction in custodial settings in Iran. First of all, I have no conflict of interest to disclose. To give you a little bit of background about Iran and prisons in Iran, the country has a population of about 85 million, and unfortunately, Iran is among the leading countries in the world when it comes to the prison population. There are about 253 establishments in the country, and since the 1980s, the number of people who are imprisoned and also the rate of the imprisonment per 100,000 population of the country both have grown quite significantly, and it is safe to say that these days almost all prisons in Iran are operating well above the capacity that was intended. And when it comes to harm reduction and programs for blood-borne viral infections, like many other countries, in Iran, prisons are always among the key settings that are targeted by public health policies and interventions, and that's because most HIV and hepatitis C transmissions do occur among people with a history of injecting drug use, and unfortunately most people with a history of injecting drug use also have a history of incarceration at some stage in their life. But harm reduction and BBV programs have been introduced in the prison settings in Iran and also in the community through a very gradual shift in policy. I'm not sure if you can see this figure on the right-hand side properly, but basically it goes back to 1979 when the Islamic Revolution happened in Iran, and we had a decade after the revolution of zero tolerance policy towards drug use, and all of the existing harm reduction programs were closed down. But this was short-lived because in 1989, the first cases of HIV were diagnosed among people with a history of injecting drug use. And between that time and 1996, there was like a short period that we saw an explosion in the number of cases of HIV in Iranian prisons. And really this HIV epidemic in the custodial settings was one of the main reasons that quite quickly in the year after that, in 1997, there were major legal reform to acknowledge addiction as a health condition, as a disease rather than a crime. And this kind of like paved the way for the reintroduction of harm reduction programs back in the community and also in prison in 2002. First, harm reduction clinics started to re-emerge in community and in prison, and in 2006, harm reduction was officially endorsed in the macro policies of drug control in Iran. And since then, we've really seen an expansion of OAT clinics and NSP programs in community and in prison. Unfortunately, the NSP programs in the prison have discontinued since 2009-2010, but is ongoing in the community. But in the prisons, we're seeing, an increase in the number of OAT clinics. About 60,000 people were receiving treatment in 2018. It is also important to mention here that in Iran, in the context of Iran, when we talk about harm reduction, it is almost always given that within the harm reduction network, some level of HIV testing or HIV testing and treatment program is always embedded. And that is because the HIV epidemic was obviously the reason for the reintroduction of all of these harm reduction programs. So it has been always kind of like an integral part of harm reduction, but also the level of funding that is available in the HIV sector is quite much we can say it's more than hepatitis C. That is through several global initiatives that are operating in the country. So there's always in prison or in community, when there's harm reduction, there's some HIV services as well. So what has been the impact of this relative large coverage of OET on health outcomes among people who use drugs? The mathematical modeling shows that the current OET coverage does have an impact on reducing drug-related mortality, for example, in Tehran in the next 20 years, and that is the impact is mostly driven by high coverage of OET in the prison setting. But obviously there is still room for improvement, both in terms of harm reduction and HIV programs, because despite having this large network of harm reduction, we still have major gaps in the HIV cascade of care. And as I said, that's not because of lack of testing or cost of treatment. These issues have been resolved in the HIV sector, but there are other problems, for example, both in community and in prison. Nurses or peer support workers who carry out testing are often not adequately trained for how to use these rapid antibody tests, or how to link people to care if someone has a positive test, or issues like that. That is beyond the scope of this presentation. But also in terms of OET, we know that if the coverage of OET is increased beyond the current limit, even higher number of deaths will be prevented. So there's definitely lessons learned and food for thought for future planning in the area of HIV care and also harm reduction. But having said all of that, we arrive at the topic of hepatitis C. So what about hepatitis C? In Iran, about 190,000 people are living with Hep C. Diagnosis and treatment uptake have been historically low in the era of interferon-based therapies. Really, there wasn't any hepatitis C testing or treatment programs in the prisons. There were here and there seroprevalence studies that assessed hepatitis C antibody level prevalence among the prison population, and we knew that hepatitis C was very highly prevalent among people who are incarcerated, but this never translated in any sort of policy or intervention at the national level until 2016, when Iran started to produce inexpensive generic DAAs, and this created really great optimism and excitement for the potential to increase diagnosis and treatment. But obviously it had problems. So here I want to mention 3 studies that have been carried out in the DAA era among the prison population in 3 different provinces in Iran. In terms of the methods, they've almost all used the same methodology, which is based on this idea of simplifying hepatitis C diagnosis and linkage to care. So rapid Hep C antibody testing has been used among everyone who enters the prison, and also inmates who were already in prison. If somebody had a positive test, a venipuncture blood sample would be taken for HCV RNA testing. That is outside the prison, and if that was positive, then APRI was used for liver disease evaluation. GPs in the prison clinic were trained for treatment initiation, and depending on the APRI score, people would receive 12 or 24 weeks of generic Hep C therapy. And also post-release care was coordinated with the local health networks, and Iran is fortunate in having a quite well-established network of primary care. So in each of these prisons, quite large numbers of people were screened, 2,000, 3,500 and about 1,200 people. Antibody prevalence was between 5 to 10% in the 3 settings, which is consistent with the literature. And also treatment uptake was quite high in all of the three settings, but there were obviously problems in each of these studies. For example, because Hep C testing was always done outside the prison, the time and coordination that was required for the logistics of collecting all of the blood samples and sending them out, and I don't know, 2 or 3 times per week, and getting the test results back and giving them to the clinic and the GP in the clinic, all of that take obviously long enough. For example, in the study in Karaj, 24% of people who turned out to have positive PCR tests were already released before treatment initiation. So that was a major issue. Also, post-release coordination with the local health networks was quite challenging in all of the settings, but especially in the Gorgon prison. That was an issue. One of the reasons is because of, that there was not enough coordination between the office that looked after releasing people and the clinic. So at the time of release, people didn't always have the information about where to go and what to do. But also, so the post-release care was not always provided at the clinics that people who were released from prison would attend. So people would often be referred to like a primary care setting, but not somewhere low threshold or, like community-based or frequently attended by people with a history of drug use. So that was another problem. So people would simply just not go to where they were referred to go to. So having all of these experiences and from all these years of having harm reduction in prisons, HIV programs, and most recently hepatitis C program, we know that there is high willingness among people to receive hepatitis C testing and treatment. We know that simplified HCV diagnosis and rapid treatment initiation is the way to go. And we also know we've learned other lessons too. For example, through all of the 3 studies that I mentioned, we've learned how important it is to use existing harm reduction infrastructure for HCV testing and treatment rollout. In most of Iranian prisons, people who are receiving opioid agonist therapy are accommodated in this specific ward, and usually most people who have hepatitis C and need treatment are also those who are receiving opioid agonist therapy. So it's been important to use this infrastructure, one, to kind of like simplify the logistics of getting people out of the wards and into the clinic on a daily basis. And secondly, because there is still ongoing stigma associated with hepatitis C, and most people don't want to be seen taking hepatitis C treatment. So it has been great help to give the medication at the same time that people go to the clinic to receive the methadone. But we're also aware of the barriers that exist to hepatitis C care, both in community and prisons. Some of these barriers are shared, for example, the cost that is associated with diagnosis and treatment, although we have generic drugs, but there is still out-of-pocket cost. There is some coverage that is offered by some insurance policies, but usually these insurance programs are associated with employment. Therefore, the more marginalized people who are not employed are not covered by those insurance programs. So it's not a kind of like a national level of access to free diagnosis and treatment for everybody. So that's a major issue. But there are also some barriers that again are common between prison and community, but more specific or more highlighted in the prison settings. One was the COVID-19 pandemic that really slowed down the existing projects, and now emerging, like prisons went into long periods of lockdown, and basically anything that was not COVID related was not welcomed in the prison. So we're now emerging from that era, and hopefully we can kind of like bring back to life those connections and networks that we had with our colleagues in prison. Also, there are major shortages in rapid antibody testing kits, and also we don't have any point of care RNA testing, and these are issues that are related to the trade sanctions that are imposed on Iran. So, so that's again like these shortages really go against that principle of simplifying hepatitis C diagnosis and linkage to treatment. So we, I guess, looking into the future, we know a lot about what to do, but there are also a lot of issues and problems to work on, and we are trying to work with what we have and hoping that we can resolve some of these problems in the coming years. And these are my contact details in case you have any questions or comments.
Unfortunately, Mariam is not connected with us to answer the questions. I would like the other presenters to come up to the stage and to open the Q&A session. Remember that you can also ask questions through the app.
Maybe I'll get started just while our presenters are coming to the stage. I think this conference has reiterated the use of peers or the integration of peers in healthcare delivery and services. In HIV, hepatitis C, and both of your models use peers to some extent. So Svetlana, for you, I'm curious how you recruit your peers as part of your program. Are they recruited from the prison or are they external to the prison? And what, other than the exchange of needle and syringes, what other services or care do they provide in the prison?
Usually we have two types of peer-to-peer intervention. If you discuss about information, education, HIV testing, can be done by NGO engaged former prisoners and representative of some key affected populations, MSM or people who inject drugs. If you discuss about first most important part, peer-to-peer intervention through the active prisoners. Usually medical staff try to select some people who can be good manager and good people to can have enough knowledge and respect from other prisoners to try to be good people who can promote some correct knowledge among prisoners. After this first stage is finalized, we need to have a very good discussion with prison manager, because they also need to approve these people as a volunteer in harm reduction services. Usually there are no objections for prison staff because they understand that is a part of medical activities. It is important to have trained people. In these sites of need exchange program, we have also condom distribution. We have some lubricant, information materials, about different topics, including overdose management, and a very short way to linkage when they identify some emergency situation to medical staff. Because unfortunately naloxone in our country is a strict evidence drug, and it's difficult to have it in the site of need exchange, but we try to have some spray on naloxone, and maybe we can change the situation.
Thanks, Svetlana. And Ian, if I can just ask you the same question, because you mentioned your model in the UK is also peer-based. Could you comment a little bit about where the involvement lies along the cascade of care?
Sure. There's several layers of peer support. So we have healthcare champions who will help people get to appointments and such like, but the Hepatitis C Trust have the expert peers. So those are the people who are going to go and do some pre-work before a hit. They're going to share the good news about the treatability. I think a lot of patients are still really worried that they're going to be put on interferon for 18 months and killed by the healthcare team, whereas, of course, we know that's not the case. And that sort of misinformation is much more credibly disassembled by a peer who's probably been through the treatment in many cases than it is by me just telling a patient that. And I think the other thing is at the HITs, at the whole prison testing events, the peers are absolutely crucial because they'll go in before the HIT, they'll spread the word about what's happening, they'll encourage people to be involved, they'll tell them about the resources that are available, the money going on your telephone card to talk to your family, the Mars bar or the Apple or whatever, so that patients are excited before we go in to do the HIT. And they actually take part in the HIT as well. So they're absolutely essential.
Thanks, Ian.
There is a question on the mic. Andrew?
A question for both the speakers actually separately. First of all, maybe for Ian. So it's Andrew Lloyd from Sydney. Ian, I wonder about, in the flavour of simplification of the care cascade, what's the approach for fibrosis assessment and what's the approach for hepatitis B testing, surface antigen testing?
Yeah, thanks, Andrew. I think that varies by operational delivery network. So in England, there are several regional organisations which actually agree to send out the treatment to the patient, and they're termed operational delivery networks. They're based in one of the hepatology or infectious diseases centres regionally, so that's a geographic thing. They'll have different approaches. So in some places, they're using APRI as a screening tool. In others, they're taking a FibroScan into the jail. So that's a variable feast. But I think that there's a general acceptance that we should not be delaying treatment to get a fibrosis testing.
And so in practice, is that the way it works? They don't delay treatment?
I don't think we delay treatment in any of the ODN areas, to my knowledge, no.
Gotcha. And surface antigen testing, it happens?
For Hep B,
Yeah.
absolutely. So our point of care test is Hep B surface antigen, HIV antibody, and
Gotcha.
Hep C antibody, yeah.
And so how do you feel about deferring the whole fibrosis assessment if it was actually an impediment to starting?
So I think what we've seen is that the people with advanced fibrosis were treated successfully some years ago. So I'm not seeing a great deal of cirrhosis now, actually. I think we're seeing fibrosis at much earlier stages. So if we happen to find that somebody's got advanced fibrosis later on, then we can tweak their treatment duration. But I'm not aware that we've had to do that, Andrew, to be honest.
And Svetlana, thanks so much, Ian. That's great. Svetlana, I'm interested in the devil in the detail about the needle syringe program in the prisons. Is it a one-for-one type program? They're saying the inmates have to bring back the previously used fit before they get another one.
Yes, we want to have one-to-one changing, and this is our goal. But usually prisoners, due to the security staff measures, try to change at the package 20 or 25 syringes, but if there are opportunity. In many cases, if the prisoners do not have opportunity to return the used syringes, it is not a problem to take a new sterile equipment. But this idea was because there are confidentiality of drug using among prisoners also. And usually there are in each prison 4 or 5 different people who every day go to these sites and change these syringes. And for non-medical staff, for security, it's also the same people. But really, in the place of living of prisoners, these sterile syringes are used by more people than one.
And one of the main concerns I know from the correctional, the custodial officer's perspective, is that this supply might increase the number of syringes in circulation outside the individual and might increase their risk of needle stick injuries. Is that what you've observed?
We have a different stages on implementation. First of all, we have a very good start point for NSP in prisons because the prison director visited Canada and saw how these needle exchange programs are working in the community. And his decision was to mandatory for all prison governors to start implementation of this needle exchange program. And in these cases, he recognized that in prison there are drug use, and we are must to decrease the dissemination of the infection diseases. After, when we try to show how in dynamics is changed the situation, there are very clear enter point by NSP and referral system by volunteers to treatment of opioid dependency. And when we start to implement treatment with methadone, the number of used syringe decreased. And usually now we have the same line, the same number each year, with very small differences, about 1 million syringes.
Thank you.
I think we are done. Thank you for the questions. Thank you, the presenters, for the nice talks, and thank you, the audience, for the attendance.